Thank you.
All right, so I request all the attention of the faculties and delegates. I will take a few minutes of yours and let me introduce me and the faculty members of the session. So good evening and welcome to one and all. This is Ankita from Clanet, the Science Session Assistant for a seamless experience. And Clanet is India's most trusted and widely used digitech platform with multiple enriching services exclusively for doctors. Clanet is very proud to be a digital partner for this event. So without any further delay, I would like to hand over the session to Dr. Suha, sir, to take over. Over to you, sir. Kindly proceed with your talk.
Thank you, Ms. Ankita. Thank you. Good evening, everybody. Welcome to this edition of the virtual classroom for in pediatric neurosurgery. This is an industry and endeavor to conduct classes on specific pediatric neurosurgical topics with the help of our national and sometimes the international faculties. And the topic this time is we are still continuing the vascular malformations in children. And this time the topic is cerebral cavernomas in children and vascular malformations in spine. So the first topic, cerebral cavernomas in children, is being presented by Dr. Vamsi, who is an additional professor at NIMS Hyderabad, and with his primary interest in functional and epilepsy surgeries. And the next colleague is who is going to present spinal vascular malformations is Dr. Sreehari, who is my colleague at Amrita Institute of Medical Sciences at Kochi, and his primary interest is intervention, neurointervention, and although he does other surgeries too. He's an additional professor here. Thank you all for joining. So we'll start off with Dr. Vamsi's talk. And in between, let me remind you that you can raise your hands at any point of time and get your questions, queries answered, or you can put it in your chat box so that we can answer the questions as it goes by. Thank you. Dr. Vamsi, you can take up.
Yeah. Thank you, Dr. Suhas, Dr. Sreehari, and everyone for this opportunity to interact with the residents on the ISPN platform. And today, the topic that was given that I'm going to do is on pediatric cavernous malformations. First of all, it's important to know, what are the different vascular malformations for in the brain. So they are categorized broadly into the high flow and the low flow ones. And high flow ones are the one which generally everyone is excited about, the AVMs and dural AV fistulas, because the surgery and treatment and a lot of stuff excites everyone. But the low flow ones are the one which are actually the one with the higher incidence. So quite often what we see, the low flow ones, the more common things. These are the more common things that we encountered in the brain and the spinal cord. So the capillary telangiectasias and developmental venous anomalies are on the top. They are quite commonly seen, but they are not so much symptomatic. So quite often they are ignored. They are detected and just not treated. So they doesn't come to the attention typically quite often to the neurosurgeon or neurologist. So the other one, low flow anomaly that we see is the cerebral cavernous malformations. So that's what we are going to deal with. And there are other anomalies, but which doesn't constitute the lot of percentage of those vascular anomalies of the central nervous system. So what are the cavernous venous malformations? They are a cluster of hyalinized dilated capillaries with surrounding hemocytry, and there is no intervening brain tissue there. So this point is very important, that there is no intervening brain tissue in the hyalinized, clustered, hyalinized, dilated, thin capillaries. It's an important point because it needs to be distinguished from the CNS capillary telangiectasias, where there is normal brain interspersed within these capillaries. So these two are radiologically very important to be distinguished, and they're being symptomatic and asymptomatic. Their entire status of how they cause symptoms and other things depends on these factors. So the having thin dilated walls is the cause, like where they end up causing hemorrhages and the micro hemorrhages to the large bleeds is something, I mean, which is because of the very nature of these hyalinized thin dilated walls. And the incidence is the prevalence of CCMs in general population is 0.15 to 0.6%. And particularly in the pediatric population, various studies have looked at it, and it's 0.2% is in infants and 0.6% is in the children. And there's no particular sex predilection for these anomalies. And that 10% of them are familial, and 17% are multiple lesions. So this cluster of anomalies are very important while various factors needs to be considered while we make treatment and other management decisions for this set of patients. So there are other facets to it. I'll deal with it as we go ahead. And the incidence of de novo development of these cavernous malformations, like there are various etiologies that have been proposed. One is like a de novo formation of the cavernomas, and prior radiation is an extra risk factor which causes cavernoma formations. And 85% of these cavernous malformations are supratentorial in children, and 8% are deep. So the etiologies are simple: the de novo formation and the radiation. And the de novo formation, like in cases where there are familial cavernous malformations are there in the cerebrum, there are more de novo formation as the kid grows. So what we are seeing today, the number of cavernomas we are seeing in the brain, after 3-4 years or 5 years, there are going to be more cavernomas because there is more and more. So that is the percentage we are looking at. 2% per patient per year is what the development of de novo cavernomas in these in the kids. So they need to be screened at regular intervals to be able to realize the number of growing cavernomas in their brains. And as far as the imaging is concerned, the CT is of not much of a value. It quite often ends up missing a lot of cavernomas. And the MRI is the one which is the modality of the choice. And a CT can pick up a large bleed, or it can pick up a larger cavernoma or a cavernoma with calcifications. These things can be picked up. But quite often, the cavernomas could be pretty small. And within a bleed, it's very difficult to recognize. So the MRI is the modality to detect all types of cavernomas, and as well as the associated any other anomalies, like because cavernomas could be associated with developmentally venous anomalies. In around 20% of cases of cavernomas, there could be developmental venous anomaly. So it's very important that we evaluate the entire different vascular malformations associated with the cavernomas, not just look at the cavernoma per se itself. So the T1 signal intensity is when we look at different sequences of MRIs, which would be useful for us in evaluating the patients with the cavernomas. The T1 images are only there when there is a large bleed, it picks up, but they are not the one which gives us the information that we look for. And T2 sequences are the one which shows us typical popcorn appearance, is the one which is shown on the T2 images. And it's a typical exam question for everything asked. What is the popcorn appearance? Is something which is it's like a spotter that's given for the residents in the exam typically. So it has a hypo-intense ring, because the hypo-intense ring comes from the micro hemorrhages that keep happening time to time in these because of surrounding the cavernomas or within the cavernomas. And there are popcorn appearances, like there are hyperintensities within the cavernoma itself. That could be the thrombosis of the blood and other changes that are happening, or small microhemorrhages resolving, they cause it. And the hypointensity is basically the hemosiderin ring. So the hemosiderin looks hypodense. So hyperintense signals within the center in different areas of the lesion, surrounded by a hemosiderin ring, which is looking as hypointense. Then the SWI. So this is a typical cavernoma where we are seeing a hypointense rim here, which is the hemosiderin ring. And there are hyperintensities and hypointensities in the center, giving a popcorn appearance. And this is the GRE image. The GRE is basically a T2 sequence, T2 GRE image. And one of the variants of the GRE image is the SWI, sequence, susceptibility weight images. The susceptibility weight image is sensitive for picking up deoxygenated hemoglobin, calcium, and hemosiderin. So that's why this is the image which is preferred for picking up the cavernomas on the brain, and this is pretty much the image that will show all the cavernomas in case someone has a multiple cavernomas. So they are this is the one which shows, and it's very sensitive for the veins as well. So because veins has deoxygenated blood, that's why it can pick up all the developmental venous anomalies too. And it shows up nicely both the cavernomas and the developmental venous anomalies that are associated with it. A developmental venous anomaly is something that the radiology is something which is very peculiar, and that's how it looks. It's called caput medusae appearance. So the developmental venous anomalies have a typical appearance like this, a caput medusa head kind of an appearance, and there's a vein lining. This is the other vascular anomaly, as we discussed. It's much more common than the cavernomas in the brain. So the susceptibility weight image picks up both the cavernomas and as well as the developmental venous anomalies. So it gives the entire diagnosis and of the entire set of anomalies that there are anything that are associated with the cavernomas. So here typically we see a cavernoma, and there is a DVA associated with it. So this SWI image has beautifully given us shown both the vascular anomalies that are present in this way. And same is true for in this case, the cavernous angioma, and there's a developmental venous anomaly. And it's the DVA that I just kept in the slide so that would be able to identify it and we can able to connect it, because it's such an it's such an impressive image that it can easily be you won't forget it once we see it. So do we require any further investigations? Quite often, like the confusion is, do we require to do an angiography for this? So generally, cavernomas are not shown on the angiography because this rate of flow of blood within these capillaries is so slow that the dye gets washed out before they take up the contrast. So they are not shown on the angiography. But in case there is any other further associated anomaly that needs to be evaluated, which is suspected on the MRI imaging, there is an indication for angiography. Otherwise, for the diagnosis of cavernomas, it's typically not required. Now, even if there is an associated DVA too, generally the DSA is not required because the SWS sequences beautifully demonstrate as the DVA associated with it. Sorry, the SWS sequences. So the other entity that is very much important when we deal with it is the familial cavernomas and multiple cavernomas. So these are quite often like these are the entities like which pose. I mean, patients come to the OPD with these scans. I mean, incidentally detected or patient has some other symptoms with this, and the scan shows up multiple cavernomas. And suddenly we are stuck as to what kind of management plan the patient should have and what other investigations we need to ask for. So the familial cavernomas they are typically they are labeled as familial cavernomas if it is associated with a positive family history, or the first or the second degree relative. And there are 3 genes associated with it: CCM, that is cerebral cavernous malformations, you can call it CCM1 to CCM3, CCM1, 2, and 3. 3 genes associated with it. And any of the patients, so the patient coming with the multiple cavernomas, and the kids coming with these cavernomas, their family members need to be screened for this. In case there is a family member, the first or the second degree, a family member detected to have cavernomas, in those cases, they are sent to the medical genetics for the evaluation of the genes. That's what we typically follow at our center. And why this is important to know about the familial cavernomas and the genetic makeup is the CCM, the 3 gene has been found to be associated more with the hemorrhages compared to the CCM1 and 2. So in one of the studies, it has been shown that by 5 years, 17% tend to have symptomatic hemorrhages. So what are the symptoms that we are looking at? The hemorrhages is some of these cavernomas are incidentally detected. Like one of the case that I'm going to show you as in the next part of the lecture is, so the hemorrhages is the presentation is in 62% of the cases. And the hemorrhages can be small, very micro hemorrhages, but depending upon the cavernoma location, they become symptomatic. Like a hemorrhage in a frontal lobe cavernoma may not be microhemorrhage, may not be symptomatic at all. The same microhemorrhage of a cavernoma in the brainstem or a cavernoma which is there in the thalamus could be symptomatic by sensory symptoms or motor symptoms, or a small microhemorrhage within a spinal cavernoma is going to be symptomatic as well, with anything ranging from sensory deficits to the motor deficits. So that's why, and a larger cavernoma, larger bleeds obviously tend to be symptomatic, with the patients coming with comatose conditions to hemiplegics to as our patients requiring an emergency evacuation for a hematoma plus or minus of cavernous cavernoma excision. So seizures is another common presentation that we see, particularly in the kids, and the parents start getting apprehensive about it, and there are a lot of questions that arise once the kid starts having seizures and a cavernoma is detected in the brain. Then the other manifestations are focal neurological deficit, just simple headache, and an incidentally detected one. So the cavernomas are one of the major causes of acute non-traumatic intracerebral hemorrhages. So if something of a kid with a pediatric patient is found to have a non-traumatic intracerebral hemorrhage, the one of the top diagnoses that we are looking at is the patient, is he or she having a cavernoma? That's important. And the hemorrhage risk it's very much important to know these percentages wise, and different lesions at different stages, what are the risks of hemorrhage, because this is what we would be conveying to the patient, the kid's parents, to make a decision as to treat, not to treat, to convince them to treat if at all a surgical excision or some other modality is planned. So it's in approximately 0.5% per lesion per year is the hemorrhage risk. And if a cavernoma has already bled, then the annual hemorrhage risk jumps to 11.3%. So moment one bleed makes the cavernoma, or if it is one, if it is a single cavernoma, or if it is in a familial cavernoma or multiple cavernomas, in those cases it gets even much more riskier to not to intervene or not to manage them by using one of the other modalities. So what are the typical chances that the cavernomas, what are the risk factors, or what are the, are there any factors by which we can predict if a cavernoma has a high risk of bleed? That's a larger lesion greater than 1 centimeter and an early age of presentation, that's around less than 30 years. And there are associated anomalies, like as I mentioned, it's the developmental venous anomaly or any other associated vascular anomalies. And a familial cavernous malformations. And that too, as I mentioned, like the CCM3 gene is the one which has, of all the 3 genes associated with the cavernomas, this is the one which has higher rate of higher risk, which are at higher risk of bleed. So then just to introduce to the next part of the lecture, I'll go to the cases later. Yeah. Yeah. We'll just run through some of the cases for us to understand the topic, how these decision makings, whatever has been taught so far, whether how the decision making is quite complicated than what we assume it to be. So there's a 13-year-old girl who has come to us with headache and 1 episode of seizure. So the kid was treated in other center, and an antiepileptics was started. Since then, she didn't have any seizures after that. So the parents came to us with the scans and said, do we require surgery? Like, because it has already been advised by some other center. So then the discussion starts with that. So we said our suggestion was this lesion definitely requires surgery, was the suggestion that we gave initially. So then comes the questions: what are the benefits and why we made the decision, and the other things. So if any resident is interested to kind of hello, yeah, anyone wants to answer the queries on this? Okay. So
I mean, anybody can ask a question if you think you want to ask to Dr. Vamsi.
Yeah.
Or you can give your opinion.
Yeah,
just raise your hand or unmute yourself.
Yeah. Anyone wants to give an opinion on this? Okay. So I'll go ahead.
Yeah.
So this is a pretty much, there are 3 factors we considered when we made a decision to go for, when we suggested the surgery for this patient. So one is like, it's a surface cavernoma, well accessible for surgical excision. And the second thing is, this is a larger cavernoma, good enough, like around 2.5 centimeters to close to 3 centimeters lesion. And this has already bled. So a larger lesion, then it has already bled, so there is more chance of seizures. And the third factor that was taken into account was it's very, very well accessible and can be, this cavernoma can be removed with minimal surgical risk. So the surgery was suggested. So the next question that has come from the parents was, would the kid be completely free of seizures after removing this? Yeah, that's where the entire this thing comes, because the parents were only concerned about the fit that the patient has got. Because The bleed hasn't mattered to them when they presented to us. She just had some headache and that got resolved. The seizure is one thing which the family was very much concerned. So in that case, we told them like around 60 to 80% of these cases get seizure-free after the removal of the cavernomas. But the typical question that comes when we deal with these things are, is the kid going to be completely free of anti-epileptics? Is the question that the parents would want to know, because they don't want to keep the kids on medication for years together. So then we told her like it's difficult to stop the anti-epileptic medication immediate after surgery. At least an year and two is typically there are no clear guidelines on this, but this is what we follow at our center. So we continue the medication for a year and a half, and do an EEG, see and stop the medication if the kid didn't have any seizure during that period, and the EEG doesn't show any spikes in that. So that's what the discussion. And we as well told them like the cavernoma needs to be removed along with the hemosiderin ring surrounding that. And at the same time, we used the ECOG guidance as well while resecting it, because the two factors, the removal of the hemosiderin ring surrounding the cavernoma and the ECOG guided resection to find if there is any adjacent cortex which is firing, like which is probably contributing to which epileptogenic cortex is there adjacent to the hemosiderin ring. So removal of these are the two factors that that we are going to consider while removing the this cavernoma. So this is fortunately not, we accessed it from the middle temporal gyrus, and we could clear it out. That's the post-operative scan. Kid so far didn't have any seizures. It's only 6 months since we have operated. She didn't have any seizures, but she still continues to be on the medication. So this is another case where there is a cavernoma, and it's a 2-year girl, and there's twitching of eyes, and there's increased frequency of the seizures, and the patient had to be admitted. So it's the concerns in this case was the cavernoma is located in the premotor area, premotor cortex, and the second thing, it's a big cavernoma. And definitely it has caused with bleeds, it has caused some edema surrounding this, and all these factors have contributed to aggravation of diseases, and that was excised. And so coming to this, the meta-analysis has shown clearly that the hemosiderin ring removal along with the cavernoma offers better seizure control. And wherever it is indicated, wherever it is considered as appropriate. So an ECOG guided resection is done. Typically, when kids have more number of seizures, in those cases, like an ECOG guided resection, adding up is always a better opportunity, a better thing to do, to have a better seizure control after surgery. So the third thing is, this is a 10-month-old boy with no perinatal events, and he was presented with the seizures, and his aunt was diagnosed with the cavernomas. So it's a familial cavernoma, and there's as well a cavernoma within the spinal cord too. And there are no neurological deficits for this kid. So he was kept on medication, and the discussion happened with the family. And since it's a familial cavernoma, and there are multiple cavernomas that would be developing in future too, and apparently there was no significant hemorrhage that happened, which is symptomatic or which caused any neurological deficits. The decision to manage the kid conservatively with the anti-epileptic medication and with an MRI scan every year is something which was agreed upon by the family too. So this is another patient, another 18-year-old girl. She met with an accident, and she got a CT scan done. The radiologist suspected a lesion, a couple of lesions in the frontal and the premotor areas. Then she came to us with for evaluation of the CT scan, a consultation for the head injury. Then we got an MRI done to know the nature of the lesions, and there are multiple cavernomas that were picked up in her brain. So this is one in the frontal and one here, and there are other multiple small cavernomas which could be seen on the scan. So the mother was very eager. Like she said, if there is anything that can be removed, you can remove it. Then we finally had to tell her, like, we discussed with her regarding the possibility of more and more cavernomas coming up. And I told her, like, it won't be beneficial to run because she is absolutely asymptomatic. It's something which was incidentally detected on a CT scan, which was done for a head trauma, head injury. And so we told her to get scans every year. And if something gets symptomatic by seizures or hemorrhage, and right now, both the cavernomas, the large cavernomas, which are likely to bleed, they are located in more of a non-eloquent areas, which may not result, the bleed may not, a small bleed or even a medium-sized bleed is not going to cause any immediate neurological deficits. So that's where she's being followed up conservatively. And the other thing that we advised was to get an MRI spine done as well for the cavernomas. And the family has not immediately agreed upon getting the entire family screening and genetic screening and other things. So these are the entire workup. The moment we start seeing multiple cavernomas, so the family screening and the genetical screening is something which automatically comes. And quite often what we end up missing is the screening of the spine for the cavernomas. And this is another case with the multiple cavernomas on SWI images. And it's a case of the brainstem cavernomas. So say a 1-year-old boy with the brainstem cavernomas, and the brainstem cavernomas, typically they become very much symptomatic. They say like the risk of bleed in the brainstem cavernomas is high because, but this is a disputed thing because the other cavernomas in other locations too, they bleed. But the brainstem cavernomas, because of the very location they are, even a microhemorrhages could become symptomatic. So there's generally tendency to pick up more of brainstem bleeds and more tendency to treat them. And the brainstem cavernomas, typically even in adults and the kids, the decisions are made based on if the patient already has a bleed, if the patient already had become symptomatic, if the brainstem, the lesion is accessible, and or else, I mean, we have to wait for these are the factors which are generally considered. And if the cavernoma is deep-seated, generally the general tendency on the part of the surgeon is it's to wait so that it surfaces to one side, but sometimes it's quite devastating because they end up in larger bleeds and a patient completely becomes patient come up with severe neurological deficits in such cases. So there's always a dilemma because surgery as well is complex, and surgery as well is fraught with enough risk of neurological deficits. And quite often in the kids, after the surgery as well, there is always a chance of recurrence, not unlike the adults. So it's always a very measured decision that we make in the brainstem cavernomas, looking at and it needs to be very seriously looked at the risks and benefits of operating upon these cavernomas. And quite often, like if the patient comes with some kind of a sensory or mild motor deficits and cranial nerve deficits, they tend to improve. and are generally, we tend to approach it surgically once the blood clears off and hemocyte ring is formed. So in that case, like operating upon this lesion and having a neurological deficit is something which the patient or the family is not going to accept very easily. So this needs to be discussed with the family thoroughly, and they have to be convinced that this is an area which is quite riskier, and the surgery is planned based upon the corridor and other things are planned after doing DTI scan under neuromonitoring and with the navigation guidance. And these are generally better done by the skull-based approaches, and that's what we need to do. And someone who regularly operates on these cases, someone who has good enough expertise, it's better that they intervene rather than operating it in centers where it is rarely done. So the treatment is, as I said, like it's the ECOG guidance and other things. I already discussed it. There are enough minimally invasive therapies that are coming up. One is the stereotactic radiosurgery. The risk of hemorrhage appear to occur. It needs to generally the SRS takes its own time to act, so it's only after 2 years. So SRS is something which has a doubtful benefit. There are publications for and against it. So this is good when we are treating the lesions within the thalamus which have bled before, such kind of deeper lesions which are smaller and which are not surgically accessible. In such cases, it's a good modality to go in for. And the other new entrant, the other one is the laser interstitial thermal therapy. So I had the opportunity to treat during my fellowship in Montreal some of these LITT for cavernomas in the kids, and yeah, the laser burns the lesion, and I generally tend to offer some kind of protection against the hemorrhage. And as well, like burning the area around causes diminished seizure, epileptogenic potential from that cavernoma. So these are the minimally invasive therapies are excellent when we are treating multiple cavernomas where you don't want, where we can't keep doing multiple surgeries. And the latest entrant in the minimally invasive modalities is the magnetic focused ultrasound, and MAGFUS typically called. It's used for functional neurosurgery for treating tremor, Parkinson, to a lot of other diseases. Now it has huge applications, and that is the one where the ultrasound beam, they are after entering through the skull, that attenuation, they are brought to one focused area to cause ablation of these lesions. So there are different mechanisms how these MAGFUS, the ultrasound, magnetic focused ultrasound works. So the spinal cavernous malformations, I'll briefly touch upon this. So the presenting symptoms could be, a lot of them could be asymptomatic, and it could be pain, weakness, and paresthesias. And there could be a gradual neurological deterioration. There could be a sudden neurological deterioration with patient becoming paraparetic. And quite often they are seen in the cervical and the dorsal areas, and lumbar, it's rarely seen. And it's very important to know what is the location of these cavernomas. And once it has bled and patient has become symptomatic, either with the sensory symptoms or with motor deficits, it's very it needs to be treated. But the problem with surgical treatment of these lesions is they are associated with higher deficits, because the the dorsal or intramedullary lesions, the planes are not so clear, and using the lesion is not something which is soft, so they are sometimes they are calcified, sometimes they are pretty firm. So any dissection that's happening within the spinal cord, because these lesions are very tiny, they end up causing neurological deficits. So the more amenable the cavernomas within the spinal cord are the one which are situated within the dorsal surface. The intramedullary and the ventral situated cavernomas, they have very high chances of the operating on them has high chances of causing motor deficits. So the surgery that the 2 or 3 cases we did in the last 3 years, like most of the patients, when they are these patients, when they are located, the 2 cases that are ventrally located are dorsally surfacing, but reaching up till the ventral surface of the cord. Means when we do laminectomy and we are seeing it on the surface, but it's extending all the way down anteriorly. Further, they end up with some or the other kind of neurological deficit, because the dissection is not so easy, and trying to use the CUSA itself can damage the spinal the fibers within the spinal cord. So these are very tricky, and quite often they are fraught with the risk of producing a neurological deficit. And many of these patients would have already improved from the neurological deficit that has been produced by the hemorrhage. So they come by and large intact to us, and surgery has the potential to produce neurological deficits. So it's a complex decision-making process as to how much benefit we are offering by treating. But once the patient has severe neurological deficits by the previous, the patient tend to accept any kind of risk that's coming from surgery. So that's how the decision-making process goes on in the spinal cavernomas. So, yeah, thank you.
Vamsi, Dr. Vamsi, thank you. It was a very comprehensive one, and I think you touched upon everything very well. I mean, the residents and trainees who are listening, you can put your questions in the chat box, and we will answer it for you. Next, I'll take up the topic on spinal vascular malformation, and my colleague Dr. Sreehari would present it. Dr. Sreehari.
Good evening. Just share the screen now.
Yes. So for the resident, these talks would be available in our Industrial channel on a later date, and these classes are held every last Sunday of every month, and the same timings. And we will plan to we continue to cover up most of the topics under the head of pediatric neurosurgery.
I think I'm not able to share the screen. I think.
Shall I stop the?
Yeah, I'll stop sharing.
Yeah, you have to stop sharing. Yeah.
Mm-hmm.
Sorry.
Yeah. Thank you, Dr. Vamsi.
Thank you.
Yeah, you can take it.
So my slides are visible.
Yeah. Yes. Thanks, Sreehari.
Okay.
Continue.
So this is regarding actually continuation of Dr. Vamsi's talk, basically covering up the vascular lesions of the spinal cord as well. As everyone knows, this is very rare entity, and in the literature also we have limited knowledge in this particular aspect of the spine. Now, spine vascular diseases, usually they are very rare, though uncommon. They are problems created by the bleed or something is very critical, and it impacts the quality of life very well. So just enumerate the vasculature of the spinal cord before I start properly into the vascular malformations and the vascular lesions. Spinal cord has basically supplied from the entire aortic branches, starting from the vertebral artery downwards, anterior spinal, posterior spinal, intercostals, and artery of Hyderabad cavities, as you know, is a multi-segmental origin of the artery of Hyderabad cavities, lumbar arteries, and the medium sacral arteries. So entire system, aortic system, is supplying the spinal cord. And when you're coming to come to the microvasculature. We have an epidural network, a radicular arteries, and a pile network depends upon the layers. All are like a plexus, and radiculomedullary arteries and sulcal arteries. So these plexuses are very rich in blood supply, maintaining the white matter in the good oxygen level. And this is regarding the venous channels. Venous channels with anatomy is very important, especially when you are having intervention with multiple routes. They have an intramedullary network, then compliance of the intramedullary veins, then and extramedullary veins, then epidural network that you have seen when you've seen surgeries also, and the external network. Finally, it drains. Most of the venous drainage goes to the intercostal veins, to azygous and hemiazygous veins. So this is a major venous drainage happens like in the spinal cord. Now, vascular lesions are classified basically based on the locations, as well as there are standard classifications. These are all for deciding the treatment, so that the standardized approach of investigation and treatment is possible. Most common are the AV shunts or fistulas, and these are very rare in children. Usually they present in the adult, though these lesions can occur early also. Special has actually added neoplastic as well as cavernous and spinal aneurysms along with these AV shunt lesions. So this is the pathophysiology. Pathophysiologically, we can classify broadly the vascular lesions into the shunting lesions, or those with shunt, or non-shunting vascular lesions. Non-shunting present telangiectasias, cavernomas, vascular tumors, and idiopathic spinal aortic aneurysms. So this is the classical description. Commonest is the AV fistula. You have the pile type. I'll come to the proper classification later. They are small or giant. And the dural fistula is epidural. This is basically based on the plane of the lesion. And AVMs. AVMs, usually it is intramedullary. You have pile epidural, and intramedullary, extramedullary, multiple planes can also be involved. This is the anatomical localized version of the lesions. The non-shunt lesions, basically, there is no existing connection between artery and venous system. We have cavernous and capillary telangiectasias, and hemangioma, epidural hemangioma, and intramedullary, extramedullary capillary hemangiomas. Now coming to the shunt lesions, which are the commonest, 70% is located in the thoracic and lumbar level. Usually, it is in adults. Presentation is more, very rare in children. We have to go by adequate imaging and try to aim at the cure of the lesion. That's the approach. Now, this is a classical classification of the Cambridge classification, what we call. The types, there are type 1 to type 5. Dural AV fistulas come and type 1. Then the glomus AVMs comes at type 2. They have a glomus like nidus. And the juvenile type is a large venous system, and the venous drainage comes type 3. These are basically of a younger age group. Then perimedullary and extradural fistulas. So these are the classifications. Subtypes depends upon A, B, C. Comes with, if you have the number of feeders or more, the subtype is added. So I'll demonstrate once more. This is the perimedullary fistula, has more subtypes. It has single feeder, multiple feeder, and giant type. And extradural fistulas called 5A with intravenous venous drainage. Now, Spexler added some more lesions into that, because this is more surgical. This fistula classification, that's why I'm showing it again. You have extramedullary, intramedullary, interdural, that plane-like classification. This is basically for surgical approaches rather than for intervention. The other one is an angiographic classification. And he added hemangioblastomas and cavernous malformation and spinal aneurysms. So this is a comparison of two classifications. I think we should know both, because the treatment is not like a single-handed or single modality. Sometimes we have to use surgery as well as intervention. So type 1 interdural type comes in the same. Here the radical artery communicates with the dural vein. Type 2 is intramedullary and pile malformations. Both spinal arteries supply. Type 3, extradural and intradural AVMs. is a complex geometric metameric lesions. And type 4 is intradural and ventral dural fistulas, pile and anterior spinal arteries, and the coronal venous plexus drains the system. This is the comparison of both. And coming to pathophysiology, when you have a shunt, there is a hemodynamic instability. So inside a small nidus, or with nidus or without nidus, is what matters difference between AVM and AV fistulas. So if there is sudden shunt across the arterial side to venous side, there is increased pressure naturally. And there is a through a nidus, it is an AVM, and without a nidus, it is a fistula. That's what the classical definition is, but combinations are there. Usually fistula carries a single draining vein, and the arteries may vary. Number of arteries feeding the fistula may vary. This is a picture of fistula classically. Now, clinical and radiological manifestations depends upon basically the type of the amount of shunt and the pressure. This is related to the venous drainage. The amount of pressure which is transmitted to the venous end leads to the hemodynamic stress, and there is chronic remodeling, which affects basically arterial as well as venous components. And these veins on the arteries, even the nidal blood vessels become fragile and dilated, subsequent formation of intra-arterial aneurysms, intranidal aneurysms, and which may rupture, or the veins can even impair the flow of the normal venous drainage, causing edema, causing congestive myelopathy. The presentation is commonly hematomegalia, is the common presentation. Rupture of the spinal AV shunts. Subarachnoid hemorrhage may also be present if the cranial location or cervical cord, dural fistulas and AVMs. Associated aneurysms has high chance of hematomegalia. Rarely, the venous drainage in this intracranial in case of some fistulas. And epidural hematomas are very rare. That's a difference between dural and epidural fistulas. These are all epidural hematomas are rare in case of spine intramedullary or intradural fistulas and AVMs. Second presentation is a venous congestion or congestive myelopathy, either due to the impairment of the outflow of the cord, due to the direct reflex of the perimedullary veins, or due to the indirect obstruction of the normal venous drainage. Lower thoracic spine has relatively fewer venous outflow channels. So mostly the changes, thoracic spine is more vulnerable to the congestion than the cervical cord. So congestive myelopathy sometimes present with the conus medullaris presentation, because the shunt could be the higher level. These are the edema can ascend or descend according to the venous drainage. If MRI is a classical finding of the AVMs or intradural AV shunt, is a poorly defined T2 defined hyperintensity. In edema changes, you can see it here, involving multiple segments, and with the tortuous perimedullary vessels. This is highly suggestive of a spinal AVM rather than a dural paraspinal vascular malformation. This is a classical picture. Then another presentation is a radiculopathy. Radiculopathy usually associated with high flow fistulas, rarely by spinal aneurysm formation or epidural intradural vascular structures, compression by the dilated veins. These are the possibilities can cause the root compression and radiculopathy. Now, vascular steel is another rare presentation, possibly basically in high flow fistulas, especially in children, usually at the vertebral level. They can produce high output cardiac failure due to the shunts. Now, intradural, coming to the proper description of the fistula. Intradural fistulas account for 20 to 30% of all vascular malformation. This include both spinal AV fistula and spinal cord AVM. Spinal cord AVM more frequent than pile AVM, both in adults and children. 70% of vascular lesions intradurally is spinal cord AVM, and 30% in pile AV fistula in case of children. Now, intradural studs are associated with some genetic syndrome as well, especially in pediatric age group. We have germinal HST and capillary malformation AVM syndromes, Cobb syndrome, and congenital lipomatous other vascular epidermal neval syndromes related to genetic mutation. So when you have a syndrome associated with a spinal vascular malformation, always do a brain imaging also, because syndromes usually have multiple levels of involvement of vascular lesions. Now, coming to spinal AVM proper, this is to the shunting through a true nidus. 25% of spinal vascular lesions, or 20%. Present in young adults to 60 years, presentation of age. Intramedullary may have both spinal and intramedullary components also as well. Primary, we have anterior spinal and posterior cell supply. 50% is located in the thoracic level, 30% in the cervical level, and 20% at the corners. This is a distribution, anatomical distribution of the presentation of spinal AVMs. Now, radiological feature, signal voids, you can see high velocity signal voids, dilated perimeter vessels, and scallop on the cord. Sometimes you can see here the MRI, you can see a scalloping of the cord, and there is edema, sometimes cytotoxic edema, and sometimes myelomyelatia to the chronic venous hypertension. Spinal angiography is the gold standard. This is one case. You can see the artery of Hartman caves is feeding the AVM here. We can have a newer facility of 3D angiography. So we have more delineated pictures of all the nidus as well as the details of the anatomy. This AVM is mainly fed by the posterior spinal arteries, marked here. Some indirect feeding from the antispinal as well. So it's a complex AVM. Now, peculiar features of the AVM is interposition of nidus, and flow is usually low compared to fistula. So intranidal vessels are fragile. That makes them more prone for a hemorrhage. Congestive myelopathy is less compared to pile fistulas. Now, hemorrhage rate is almost similar to cranial AVMs, 4% per year. Well, it increased to 10% when the previously ruptured ones. So ruptured ones requires treatment. Spinal cord AVM associated hemorrhage may also caused by aneurysms, perinidal or intranidal. Usually it is seen in the cervical cord AVMs. Perinidal also involved mostly anterior spinal artery. So these are the anatomical peculiarities of the AVM. Treatment is mainly multimodality. Both surgery and embolization have a role, and both are challenging. But the advantage compared to cranial AVM is if you have a targeted embolization or a targeted feeder control, the AVM the bleeding chance can be controlled. Total excision may not be possible sometimes, as the cord dissection is challenging. So that is the advantage compared to the bleeding rate comes down when you control the feeder. Safe resection with monitoring is a described surgical approach. Surgery actually has better results in the posterior or posterior lateral located AVMs, especially from the posterior spinal artery feeders. Pile resection and basically blood ones will have some plane of dissection. Even subtotal surgical devascularization may suffice to prevent the recurrent bleeding. That was the point compared to brain AVM. Some advantages are there for the spine AVMs. When it comes to intramedullary spinal AVM, proper intracaudal or pure intramedullary ones, they will have a lot of dissection in the spinal cord. So that such cases are better for embolization endovascularly. This is one cervical AVM embolized with the glue in acetyl butyl glue. It's a complete occlusion. So such AVMs, pure intramedullary ones, are good for embolization. Other embolic agents, sclerosing agents such as onyx could sometimes have controversy, especially when you have a very deep-seated AVMs, because there are sclerosis of arteries, so they are sometimes not recommended. Glue embolization is becoming very popular. Now coming to the second part, second variety is a pile fistula. These are more superficial lesions than compared to AVMs, directly but usually by the anterior spinal, rarely from the posterior spinal arteries. These were previously known as perimedullary or fistulous type or type 4 spinal fistulas. This is the plane. You can see this plane is more superficial, but the problem is sometimes more anterior. And the common variety is a phylum terminale type of pile fistula. Shunt occurs from the phylum terminale, which is a continuation, artery of phylum terminale, which is a continuation of anterior spinal artery. You can see the demonstration of the angiography here, MR angiography, high resolution. So the vein of the phylum terminale, which is a continuation of anterior spinal pyramidal vein, this presents with edema and congestive myelopathy, mostly in most patients, rarely hemorrhage. Sometimes there could be flow-related aneurysms. This is the surgical resection depicted here. And pile fistulas are better preferred, higher level, preferred with angiogram and embolization. This is an angiography showing a pile fistula. This is the anterior spinal artery shown in the blue star, and the two posterior spinal arteries here, and this is a nidus. You require multiple selective angiographic pictures at most of the levels to identify most of the feeders. And there are two types of pile fistulae, microfistulae and macrofistulae. This is further classified this year. I'm not going to the details. This is for the academic interest. Type 4 is simple ones with single branch and multiple artery feeders, and the giant one is called comes under type 4C. So the pile fistulae, the difference in the younger population and the older population is macrofistulae is common in younger patients and children because these are associated with hereditary syndromes like capillary malformation syndrome, telangiectasia, etc. And microfistulae are common in above 50, usually idiopathic or traumatic. So usually sometimes the classical presentation of HHT, hereditary telangiectasia associated with the autosomal dominant disease. Then the treatment is simpler compared to these AVMs because mostly it is a surfacing lesion. Both microsurgery and endovascular therapy are better, and we get a better cure rate in both basically. And the goal of treatment with surgery is disconnection of the fistulous connection of the arterial side or embolization. Long-term results are good because relief of symptoms up to 70-75% is obtained. Now coming to AV shunts located outside the located in the spinal canal, other varieties such as dural AV fistula. This forms such a major shunt lesions inside the spine, but is very rare in children. Usually they are acquired. It's almost like a disease of elderly or adult. The peculiarity here, the feeding artery is a radical medial artery. Could be contribute from the spine cord. The artery will be much proximal, contributing to ASA or PSA. And the vein is always almost 1 centimeter away from within the dural portion. And it never presents with the radiculopathy. So these are the three peculiarities of a dural fistula. Usually they are low flow systems. Congestive myopathy is the commonest presentation due to the reflux of the into the perimedullary vein, can produce hemorrhage. This is the classical appearance of a fistula in MRI. You can see a tuft of blood vessels, veins, dilated veins in the T2 signal the MRI. There will be cord edema here. This is the cord edema. The veins can produce sometimes mass effect also can produce a scaffolding here. This is a property picture. Dural fistula here. Surgery basically both are equally effective. using embolization, glue material, or disconnection of this shunt. But when you do endovascular treatment, the liquid embolic actually reach the footplate of the vein. So otherwise, there is a chance of recurrence. Coming to the other fistula, so epidural AV fistula, very uncommon in children, but there is an entity, this is for completion's sake. Shunt is in the epidural phase. This is behind the vertebral body in the epidural space. MRI shows like a tuft of veins in the epidural plane. This both kind of modalities, endovascular as well as microsurgery, are equally effective. Now coming to shunts outside the spinal canal. I'm describing this because this is little more common in children. Usually it's a high flow fistula called as paraspinous fistula, mostly common in trauma. And cervical is the most one of the common variety, cervical vertebral fistula. Usually the consequence of trauma and collagen vasculopathies. And due to the large veins, there will be congestive myelopathy as well as compressive symptoms in the spinal cord. Now, cervical fistula can produce paraspinous fistulas like this, can produce tinnitus, pulsatile tinnitus. Rarely it can produce the steel symptoms or ischemic symptoms. This is best treated with a combined transvenous, transarterial, or combined approach of endovascular therapy. Sometimes surgery may be required post-embolization to reduce the bulky vein thrombosis caused by the embolization. So laminectomy, decompression may be required in some cases. Now, one word about spinal artery metameric syndrome is basically a syndrome in children, very rare. As the name implies, this vascular malformation involved multiple tissue layers. This is associated with the Cobb syndrome and other AVM syndromes of the brain. Spinal cord, bone, parasites, musculature, skin, subcutaneous tissue, every part of the metaber is affected. But sometimes the phenotype presentation may be less complete. So at least 2 at AV locations in the metameric distribution is found. It's a criteria, says it comes under this classified disease. The prognosis is rarely, little poor because the treatment is a little difficult. And they present mostly with bleed or myelopathy. Now come to the non-shunt lesions. Spinal cord cavernous malformations. I think Dr. Vamsi has covered this malformation bit in this talk. I will just run through the slides. Then vertebral hemangioma, which is a common thing which is seen in the routine scan, and telangiectasias. Spinal cord cavernous malformations, as the name implies, there is no arteriovenous connections, and the presentation is rare. In children, that's actually up to 1% of intramedullary lesions. It can present from 2 years to 88 years. Could be intramedullary, extramedullary, or intradural extramedullary. Presentation almost like tumors or with hemorrhage. So there are 4 clinical patterns observed in spinal cord cavernomas. Other than pain, weakness, and paresthesia, routine symptoms. The episodic symptoms. This is basically a description given for cavernomas of the spine. There is some varying degree of recovery between episodes, slow progression and of the neurological decline, acute onset with a rapid decline, and acute onset of mild symptoms and subsequent gradual decline over weeks to months. This episode basically is because of the multiple episodes of hemorrhage happening inside the cavernoma. Progressive hemorrhage will cause microhemorrhage, lysis. Pathology, like any other cavernoma, is already been described. Mostly located in the thoracic cord. Second location is cervical cord. It's occurred in CT and angiography. The gradient echo, blooming sign, and popcorn appearance in T2 is the classical presentation. This is the cervical cord cavernoma. Blooming is seen in the gradient echo. The treatment, surgical resection, as Dr. Vamsi discussed, is not very easy. But some of the criteria has been described, whether not to treat or treat, and the timing of the treatment, surgery versus radiosurgery. Radiosurgery is rarely done in spine. So the treat or not to treat, this is the algorithm so far in published papers. When you have a symptomatic cavernoma with deficits surgery, you can go ahead with surgery. And asymptomatic ones, when you have more than 3 to 4 millimeter in size, and surfacing ones, you can go for surgery. And evidence of enlarging ones, growing type of cavernomas, especially in children, and with hemorrhage, that goes for surgery. And those of which are very small, less than 3 to 4 mm, is for serial imaging follow-up. So this is a rough algorithm, but it's getting because since the rarity of the disease, it's very difficult to get a proper chained, completely recommendation for this disease. Now, coming to common benign lesions, that's vertebral hemangioma. Mostly they are asymptomatic. And you find in most of the routine scans as a what you call corduroy appearance or jail bar appearance. This is a classical CT picture. Or polka dotted appearance, salt and pepper appearance of the vertebral body. Usually present fractures with trivial trauma. Otherwise, the treatment is just of mostly doesn't require any treatment. MRI shows some lipid rich high signal, and typical ones have lipid poor low signal, and well contrast enhancing lesions. There are multiple treatment options, which are symptomatic cases or large ones with compressive lesions, radiotherapy, kyphoplasty, embolization, and surgery. Because the bleeding is very high, so always go with a preoperative embolization. Then the rare variety, for the completion's sake, epidural hemangiomas. It's a very rare lobulated lesions seen as epidural masses, could be capillary or cavernous size hemangiomas. Cavernous usually a little solid. MRI you can see the epidural T1 weight and T2 height peripheral contrast enhancing lesions. Intermediate signal. Now, intradural extramedullary capillary hemangioma, usually seen in lower thoracic wall. This is another vascular anomaly, extremely rare in spinal cord, and they produce mostly present with bleeding. And treatment is surgery. Is recommend en bloc resection. So, treating a vascular lesion spine, basic principles to understand the angio architecture with sufficient imaging, especially a DSA. And each patient treatment should be individualized depending upon the clinical presentation. Thank you for the patient listening.
Yeah. Thank you, Dr. Sreehari, and thank you, Dr. Vamsi, for a very lucid and elaborative talk on the topic. I request if there's any questions from this to the speakers. So I think we've already gone beyond time, so we are getting the permission to stop it. I really thank you all, and the next session will be in the month of March because we are having a national level meeting over there. Thank you, everyone. Good night. Thank you. Thank you, Dr. Sreehari, and thank you, Dr. Vamsi. Thank you.
Thank you. Thank you, and good night, Doctor.
Thank you.
So with all the due permissions, can we conclude the session over here, sir? Hello.
Hello. Hello.
Yes, sir.
Sankita, thank you very much.
Yeah.
We had to abruptly stop because of the time. We're running out of time.
Yes. Thank you so much, sir. Thank you. Thank you.
I'm sorry. Good night. Thank you.
Good night. Good night, sir.
Thank you.